Perfect. Great. So, good evening, everyone, and welcome to today's sessions of UKUA STEM Pro, a program organized by the Ukrainian President's Fund for Support of Education, Science and Sports in partnership with the University of Warwick, with support of the UK-Ukraine Academic Diaspora Network and the UK Foreign Commonwealth Development Office. So our topic today is the trials, impact, and dissemination, an essential area for everyone working on research design, evaluation, and real-world implementation of STEM initiatives. We're honored to be joined by Dr. Harbinder Sandhu, Associate Professor and Practitioner, Health Psychologist at the Warwick Clinical Trials Unit, and she'll correct me if I'm wrong, will provide us with valuable insights into how to design meaningful trials, measure impact effectively, and communicate results in ways to drive real-world change. So please join in welcoming Dr. Sandhu, and let's begin today's session.
Thank you. Can you hear me okay?
Yes.
Yep, brilliant. Oh,
yes.
You'll have to excuse me, the lights have just gone off. I just have to go on them.
No worries. We thought it's only in Ukraine, right? But it's the lights off can go somewhere else as well. Okay.
Sorry about that. So the
No
lights are
worries.
set, so they make us move basically, so we're not sat for too long, which is probably a good thing. But yes, thank you so much for inviting me today to present about my clinical trial. So I'm a health psychologist by background, and I've been working at Warwick University for around about 22 years now, and I joined the clinical trials unit in around 2011. So my sort of area of research is very much embedded in behavior change interventions and testing them within sort of for clinical trials. So today in particular, I'm quite honored to be able to share with you one of my clinical trials that's just finished. Well, it got published in 2023, and I was chief investigator of the trial with my co-chief investigator, Professor Sam Eldarbe, who was a consultant in pain. And the whole trial, we had a team of 22 co-investigators. So it was a very complex trial, and hopefully I really today just want to walk you through what the clinical trial was, and then a little bit about sort of where we are now in terms of impact and implementation, and some of the challenges that we faced when we were delivering such a complex trial. So just a little bit of, that's not working. There you go. So just a little bit of background of where we're based. So I'm based in the Warwick Clinical Trials Unit, which is the little building in the picture you can see on the left hand side of the screen. So the Clinical Trials Unit was established and became fully registered in 2005. And within the unit, we have very much interdisciplinary team working. So our main sort of areas or expertise falls across 4 main groups, which are the clinical trialist group, statisticians, so the statistics group, health economics, so really looking at a lot of cost effectiveness and health economic modeling across all of our trials, and then trial operations, so really the day-to-day management of our trials, and ensuring they are delivered and meeting all the regulations that need to be met for trials to be successful and safe. And then across, I guess, we have our main themes. So these are the areas of our trials that we deliver within the Warwick CTU. And they are emergency and critical care, surgery, pain and rehabilitation, which is where my main area of work is. We have a large portfolio of cancer trials and also clinical trials methodology. And as a methodologist, I'm very much around the design and testing of complex behavior change interventions. So within the unit, we have over 150 staff, and we are growing. And that includes clinicians. So we have medical doctors, physiotherapists, psychologists, nurses, paramedics, and also, as I said, statisticians and health economics people with health economics expertise. So it's very much about interdisciplinary working within the unit, which is great. A lot of our trials, I should say, in terms of our funding, are funded by the National Institute of Health and Care Research, the NIHR. So I think we're one of the CTUs with the largest portfolio of NIHR-funded clinical trials. So in terms of where I come in from the behaviour change perspective, when we think of a clinical trial, very much, the aims are, it's a research study. We normally have human volunteers, and we want to sort of ask specific or, answer specific scientific and health questions. That's a typical sort of definition of clinical trials. And this could be evaluating the safety and or effectiveness of drugs. It could be devices, preventative measures, but also different treatments. And where my work tends to fit in is around the treatment area. So I'm involved a lot in phase 3 clinical trials and non-pharmacological interventions, very much based around behavior change. So how do we define a complex intervention? So are we thinking about clinical trials and the kind of things we do? A complex intervention is an intervention that has varied components and properties, which will target specific behaviors. They will require specific expertise and skills by those delivering the intervention, but also by those that are receiving the intervention. So there's often quite a lot of training that goes into the interventions when we're delivering them. They could be group-based interventions or one-to-one. And there is often a level of flexibility of the intervention and the components as well. But quite often the complexity of the intervention normally will map onto the complexity of the health condition that we're targeting. And as you'll see when I talk through my clinical trial on chronic pain and opioid reduction, it's a very complex condition, hence why a multi-component intervention was the one that we chose to test our research question. So I'm going to talk about my clinical trial on opioid reduction and in particular on chronic pain. So very quickly, a couple of slides on a bit of background. So when we talk about chronic pain, this is long-term pain. Pain is an unpleasant sensory and emotional experience. It's normally associated with or resembling that associated with actual or potential tissue damage. But in particular, what we're interested in is chronic pain. So that long-term pain that persists for or recurs for longer than 3 months. And that is the current definition of chronic pain. Chronic pain is currently the leading cause of disability worldwide and in Europe. And it is complex. The latest sort of definition by the International Association for the Study of Pain very much emphasized this complexity by drawing in a biopsychosocial model. So really integrating the physical aspects of living with pain with the emotional, psychological, and the social components, which are really crucial for understanding how chronic pain can affect someone's life, their treatment and their management. And really, we need to be targeting all of those components in order to help people improve their quality of life. So currently, it's estimated about 1 in 5 people in Europe are estimated to suffer from chronic pain. And there's some research which suggests with an estimated cost of around 12 billion euros. And that is because just of the impact that chronic pain can have on someone's life. It could be their inability to work. It could be, really exploring different treatment options, whether that's surgery or through medications. So it can be quite a very debilitating condition. 1/3 of patients that have chronic non-cancer pain are prescribed an opioid. So, that's quite a shocking statistic. I mean, we know that, opioids play a part for a lot of people, but as you'll see as I go through the trial, that a lot of work has been done to sort of tackle the overprescribing of opioids. So what we found in the UK, that over the past decade, we saw quite an increase in the prescription of opioids in the management of non-cancer pain. There was around a 400% increase. And then between 1993 and 2019, we saw a fourfold increase in opioid-associated deaths in England and Wales. And I think, you know, it's only really over the past couple of decades that we've started to get the evidence that long-term use of opioids to manage chronic pain is not effective in managing pain, but also it could lead to dependency and opioid-associated deaths as well. When I started the trial, which I'll talk a little bit about as I carry on through the slides, it was very much around the time where in the US there was a lot of attention around the statistics suggesting that they were going through an opioid epidemic. The amount of people that were actually dying due to an opioid overdose overtook the number of people that were dying due to road traffic accidents. So, you know, it was a huge problem over in the States. And there were questions asked about the UK, you know, are we following that trend? When we were looking at statistics with a 400% increase, the question and the worry was, are we also facing an epidemic, an opioid crisis in the UK? So that's really where my trial comes in. And it was a commissioned call by the National Institute of Health and Care Research to say, well, we need to obviously help people to taper off their opioids safely, because at the time there was no evidence on what types of interventions can actually help people come off their opioids. And what we've seen recently, I guess between 2019 and 2023, there has been a slight dip in the prescription of opioids. And you know, there's positives to that, with an estimation of saving 350 lives and 2,100 instances of harm. And that is because there's a lot of sort of, there's been more guidance released. There's obviously more evidence coming out from obviously trials like ours as well. But the prescribing rates are still quite high for opioids in general. So in terms of opioids, these are drugs that from natural and synthetic sources that interact with the opioid receptors. And common examples of opioids that we see could be like morphine, oxycodone, fentanyl, buprenorphine, tramadol, and they come in all sort of, you can have them in tablets and patches and also liquid form as well. But as I said, I think, you know, it was really over the past couple of decades that really the emphasis has now come in terms of research showing the impact of long-term use and the side effects that come with long-term use of opioids. They were never really designed for high doses for long-term use, especially with sort of chronic non-cancer pain. And here is a list of some of the, you know, really sort of typical types of adverse effects that have been reported in research, and especially things like I said, you know, increased risk of dependency, opioid associated overdoses, and also higher risks and falls and fractures as well, leading to mortality. So, you know, there was a real emphasis on why we should be doing research in this area. So when I talk about evidence and why our trial was actually pulled together in the first place, so we actually put this funding application in 2015, and we actually got funded in 2016. So around that time, there was no evidence at all. There was no guidance really on how to taper safely, because obviously with something as strong as opioids, just stopping abruptly could lead to withdrawal effects. So what we wanted to really do is design something that was safe and help people make the decision to taper in the first place. So there has been a current systematic review by Avery and colleagues, which really looked at the effectiveness of interventions to reduce or discontinue long-term opioid treatment. And the reason I've put this up really is just to show that there aren't many randomized controlled trials which are of good quality, which could really give us information of what types of interventions are useful. But there is a trend for when we're looking at particular types of non-pharmacological interventions, the types of components we can be including in those. So they actually included a whole host of different types of interventions, but in particular, I want to draw your attention to the pain self-management, which is really where coming in terms of a behavior change perspective. And this includes things like cognitive behavioral therapy, mindfulness, education, physical activity. There could be inpatient or outpatient programs. There could be sort of group sessions and one-to-one. And what the review found was that when they looked at opioid discontinuation sort of altogether, there were a couple of RCTs which had sort of moderate effect with a risk ratio of 2.15, which really favored self-pain management programs to help people come off their opioids. So giving an indication that, okay, so self-pain management programs could play a part for people wanting to taper. And then when we look at opioid dose reduction, again, the trials that were included showed favor towards pain self-management. Again, the mean difference was minus 14.31, favoring the self-management, but the evidence was sort of weak to moderate for those. So our trial was published after this, so we're hoping obviously other systematic reviews will then obviously take into account our evidence as well. But the main aim of this review is just to show that there was indication of using self-management type programs based on behavior change to help people taper off their opioids. So in terms of what we know, pain to help people withdraw. So when we're designing trials, and we're thinking about, okay, you know, this is an intervention, we want to test it in our population. We also are thinking steps ahead. So when the trial finishes, what does impact and dissemination look like? And ideally, what we want to do, if it is successful, we want to be influencing policy change and guidance. So at the moment, the current NICE guidance in the UK basically states that when we are, even before starting opioids, really we need to be having discussions with patients to ensure is the right course of action to take, have other options being explored, maybe non-pharmacological like self-management of pain, and also ensuring that they have the opportunity to ask questions and they are supported in any decision making that happens regarding their pain management. So the NICE guidance are currently published, but there's also Opioids Aware, which has got guidance produced by the Faculty of Pain Medicine, and also the British Pain Society and the European Federation of Pain have all got sort of very similar guidance in terms of the communication is important and ensuring the patient is involved in the decision making. So really to think when we're thinking about trials, where are we going after the trials finish, and it is to basically have impact on such guidance. So the iWatch trial is improving the well-being of people with opioid-treated chronic pain. So that's the title of the study. Like I said, when we started the trial, there was limited evidence. There was limited clinical guidance, and there was a real desperate need to inform practice. So we were guided by our the NIHR commissioned call about, you know, what they wanted to answer. They wanted an intervention that would help people come off their opioids safely. So the primary objective, so it's a pragmatic, multi-center randomized controlled trial. So we very much tried to keep it as much to the real world as we could. And the aim was to test the effectiveness and cost effectiveness of a multi-centered self-management intervention which targeted the withdrawal of strong opioids. And our outcome measure, our primary outcome measure was for people, the primary outcome measure was the interference on daily activities. So again, this was very much guided by our commissioned call, and we set that as our 12-month primary outcome. So in terms of where we recruited from our trial, so although we, you know, once we started this, engagement with stakeholders is very important. So this included understanding the landscape of what was happening in the UK, and there was definitely regional differences in terms of opioid prescribing, with higher prescribing in the Northeast. And our setting was primary care, so we purposely targeted patients from GP practices, general practices. and the intervention was delivered in the community. So again, that engagement there was with our stakeholders, and these were people with lived experiences of having chronic pain every day and lived experiences of opioid use. We spoke with them, we had focus groups with them, we included them in the design of the study right from the beginning. And they actually fed back to us that they preferred the intervention to be in the community rather than in a hospital setting. So as we're running a trial, every time we're engaging with different stakeholders, they're helping us design and refine what the trial should look like. And people with lived experiences are a key component of our trial. And they were involved in the co-creation of our intervention as well. In terms of very quickly who we included in our trial, the main thing here is they were patients who had chronic non-malignant pain, and they reported using strong opioids for at least 3 months and on most days in the preceding month. We did exclude people with chronic headaches because we were also running a program grant at the same time, recruiting from similar GP practices. So we very much focused on chronic non-malignant pain. And this is the list of the opioids that we included. At the time, we used the British National Formulary, which defined strong opioids as the list there. So anyone that was basically on any of these were invited to join the study. So the primary outcome was at 12 months. Which again, for a clinical trial of this kind is almost, I mean, I have been asked questions, you know, what happened beyond the 12 months, but that at the time was quite a long-term follow-up, considering the intervention was sort of 8 to 12 weeks. And the two main things, well, the first main primary outcome was activities of daily living, which we collected using a self-report questionnaire. And the target difference we were looking at was 3.5 between our intervention and those in the control. Now, we did want opioid use as our second primary outcome, but there was a big question mark around this trial when we started, whether we would actually be able to recruit people to the study. Because, you know, we're asking volunteers to join a study to make a decision to come off their opioids, which is something that they've been using to manage their pain. And we weren't particularly giving them any other medication. What we were doing is a non-pharmacological self-management type program. So because of that, there was question marks whether we would actually be able to recruit enough participants to have 2 outcome measures. And I can say one of our other learnings of the trial has been, because of the topic area, it was quite it was in the media quite a lot throughout the lifetime of the study. And that allowed opportunities for me to go onto the TV, whether it was a BBC Breakfast News or lunchtime news channel. I was invited to various like radio interviews to really talk about the study, what the study was about. And that really put the study in the limelight, and therefore I think that helped with our recruitment of our participants. So we actually ended up over recruiting. So our original target was 568, but we ended up recruiting 608 people. So because we over recruited, we were able to have 2 primary outcome measures, and then we had a whole host of secondary outcomes as well. So in terms of the iWatch intervention, again, just to give you a bit of an insight into how we develop in trials a complex intervention, we based it on a behavior change model of the COM-B, which is basically the target behavior is opioid tapering. And specifically, we wanted to ensure that patients had the capability, the motivation, and the opportunity to decide to make that opioid tapering decision and then to kind of stick with it as well. So in terms of capability, this can be split into psychological capability and physical. So in terms of psychological, the cognitive functioning, you know, these are patients that live with chronic pain. They're going to be on quite high doses of opioids. We had to think, you know, we need to design something that they're able to remember, that they're able to go away and sort of consolidate what they've learned during our sessions. So we produced DVDs, we produced summary handouts, we produced materials that allowed for some of that thinking to happen outside in their own time, so not just when they were with us for the intervention. And then executive functioning, we gave them the opportunity to reflect and to think and to set their goals in more tailored sessions rather than being in a group session. And then the physical capability is really, we thought about, you know, how are we going to help them make the lifestyle change and everything around the opioid decision making process. And then for motivation, again, this really we targeted in terms of reflective motivation. So giving them an opportunity to think about their beliefs about tapering, their concerns, do they have the confidence to be able to taper? And then the automatic processing is making them aware of the habitual perhaps behavior. So if their pain gets worse, they may have been on the tapering journey, but then reach out for an opioid. So really making them aware of the anxieties they may feel when they are going through the tapering process. And then finally, the opportunity. So the third component of that behavior change model was making sure that, you know, we really thought through, do people have the opportunity? Are they able to travel to our intervention? Do they have access? Who's going to actually do the tapering? So all these components go into designing an intervention. And again, when we do this, we are collaborating with our co-investigators, but also different stakeholders as well. So we hold meetings and focus groups. So this is what the intervention looked like. So it involved 3 full-day group sessions plus one-to-one support. So they would come for 3 days. It was 1 day per week. And then they would have 2 face-to-face sessions with a trained nurse plus 2 telephone sessions, which was the more tailored part of the tapering. So this is where the complexity comes in. So if you remember earlier, I said, you know, what is the complex intervention? This is it. So basically, it's got different components. You've got different topics. People delivering it were nurses and lay facilitators, and then you got your group and your one-to-one. So I guess the key part I just want to highlight here is who delivered our program. We trained clinicians, but we also trained lay facilitators. So these are people with lived experiences of chronic pain and experiences of opioid reduction. And that to us was, you know, there's not many programs that have that as part of someone actually delivering their program. So it was very good that we were able to incorporate that into our intervention. And then key components of the group session. So what we were told in our feedback when we were piloting it is, you know, have sessions around opioid education. What are opioids? Why were people prescribed them in the first place? You know, what effect is it having on them? Some people didn't even realize the side effects. And then talk about the general pain management skills as well. So they really guided the types of topics that we would use. The other thing we did as part of the program, so this wasn't planned, this happened sort of after, and we collaborated with our programming team in the clinical trials unit. We actually developed an app which the clinicians were able to use. So basically the patient would join the study, and then during their one-to-one sessions, the nurse could plug into the app what opioids they were taking, and then the app would generate the plan. So it was a 10% weekly 10% weekly reduction of their starting dose until 30% was reached, and then 10% of that remaining 30%. I think the main thing here is to emphasize that this was not forced tapering. It was a shared decision making. They could be paused at any time. And really, it was the GP that ultimately did the prescribing. So it was a recommendation that we would give to the participant's GP. And then because it's a randomized controlled trial, that was the intervention. The control intervention was I collaborated with my colleague who was a co-investigator, Professor Andrea Furlan, who is based in Canada at the Toronto Rehabilitation Institute. And they've developed a book called My Opioid Manager, which we adapted for the trial here. So it's a comprehensive self-management booklet. And those patients and the participants in the control group also got a relaxation CD. So already you can start to unpick the kind of complexity of the trials. Not only have we got complex intervention, I had international colleagues as well who were part of the study team. And we actually adapted one of their self-management program booklets. So in terms of results, very quickly, I'm just going to go through what we found. We recruited from 191 general practices with a list size of just under 2 million. So we screened just under 2 million people. And I think, you know, that in itself was a huge success of the trial. It was definitely because we over-recruited, it was not what we had planned for, but it was brilliant to be able to then reach out to many more GP practices. We had a total of 608 randomized at the end, and their mean age was around 61 years. 60% were female, and 3% gave their ethnicity other than white British in the study. So in terms of our baseline measures, most of the participants were at the lower band of morphine equivalent doses of opioids, but we did have some in the higher bands as well. And clinical feedback that we've had is even those on the lower end of opioid use still find it very difficult to taper. And then in terms of baseline pain interference and pain intensity, they were matched between the control group and the intervention group. Most of our participants had pain for more than 5 years, and they were also taking opioids for more than 5 years. And very typical of community care general practice, the majority of our patients were musculoskeletal conditions, so lower back pain was quite common. So we ended up delivering 35 groups in 25 community locations. Average group size of around 9. So 35 groups, again, that's quite a lot of resource that goes into delivering them, because we need to set up the rooms, you have to make sure we have enough people, randomized, pooled, and then randomized to the groups to deliver. And then we have sort of all of our data on who attended day 1, who attended day 2 and 3 of the program. So again, when we're designing trials, we need to also consider, you know, what we classify as compliance and adherence to the study. So full adherence in this study was attending all 3 days, at least one face-to-face appointment and one telephone appointment. Minimum adherence was at least attending one group day and one face-to-face appointment. The total follow-up rate was 72%, and our withdrawal was around 60%, which is, again, in terms of withdrawal, it's quite typical what you would see in these types of trials. So what did we find? Did we make a difference on their pain interference, on their daily activities, self-reported at 12 months? So if you remember, I said at the beginning, our target difference was 3.5. So we didn't make a difference at 4, 8, and 12 months. So they were not significant in terms of pain interference. But also we didn't make their pain worse. Now, this is a finding in itself, because although we didn't make a difference on their pain, what we did make a difference is on their opioid discontinuation. So complete cessation of opioids at 12 months for an intention to treat analysis was 29% of those in the iWatch intervention came off completely, compared to 7% in the control group, and the odds ratios are presented there. So the narrative here is people actually were able to come off their opioids and it didn't make a difference on their pain. So quite often a big question mark of whether people want to discontinue their opioids is, should I come off because my pain will get worse? So that as a finding is quite important. In terms of 50% reduction, we also made a difference. So even at 12 months, 57% of people in our intervention group had reduced by at least 50% compared to 27%. So the iWatch intervention was successful. We were able to reduce people from their opioid use. So this graph just shows, so the bold line shows opioid use, the goldish line, and the dashed one is for opioid use in the control arm. And you can see there's a big decrease for those that were in the iWatch intervention, and that kind of sustained for 12 months. The dark blue line showed the pain interference, and there wasn't much difference between the intervention and the control group. Did we make a difference on the secondary outcomes? No, none of our secondary outcomes were significant at 12 months, although at 4 months we did find self-efficacy, and also HADS depression scores were improved. And typically what we would find in this type of intervention is people's confidence and self-efficacy towards the end of the program is quite high. So you would expect that to be the case to triggering the behavior change. We did also report on serious adverse events, and all these have been published, and there were no deaths that were related to the study. So alongside this complex trial, we have the quantitative data, but we also had a team doing qualitative interviews as well, so the process evaluation. And again, in these types of trials, and I guess why it's important to highlight this is to understand the meaning and the why, the qualitative data is quite important. And we've published different papers just based on the process evaluation. So this, our team looked at sort of manual adherence. So were they able to deliver? Were the people we trained delivering the course as they should have done? What was their competency of delivery? And they also observed one-to-one sessions, and overall competency and adherence was good and acceptable. And then they interviewed our participants on the study. So what we found is there were overarching themes, and the overarching themes were participants said, really, it's around the right time. Whether I decide to reduce my opioids really depends on what's happening in my life at that time. What other things am I having to deal with? What other appointments perhaps do I have going on? And they really describe their living about their life and sort of how living with chronic pain is complex. They did also talk about needing support, and the iWatch intervention gave that, both in terms of group support and the one-to-one as well. So what they found was that iWatch gave participants an informed choice. Participants felt empowered to decide if, how, and when they taper. It gave them education around opioids, which is what they wanted to really start making that behavioral change. It gave them skills in pain management. So although we didn't give them another opioid or another medication, what they were getting is skills in self-management of pain. It gave them motivation. So what they said is they really appreciated that group part of being with other people. And it gave them the confidence to be able to actually go through the opioid reduction. So, you know, the iWatch program was successful. Now, in terms of the clinical trial, it was a large team, as I said. A lot of work went into, I mean, all in all, we started in around 2015, 2016, and we published in 2023. So that's how long the trial had been going on for. We haven't published the cost effectiveness results yet, so they are coming. We have a health economics team that are working on those, but the clinical results have been published, and they were published in JAMA. And when they were published, we did a press release with the university, and also the journal did their own press release in the US as well. And that press release went over social media, I think it was Twitter at the time, and then obviously we did our own. So what this meant is that we had a good altimetric score of 1,362, which shows some of the impact it's had. I think it was mentioned in over 165 different news outlets over nationally and internationally. And then it also meant that it gave us the opportunity to talk about our results. So what that meant was doing, again, similar to when the trial was running, radio interviews and televised interviews as well. And what I particularly found about those opportunity was quite often there could be maybe some people may have misunderstood some of the results, or maybe flagged up questions which you can't always answer that well if it's on Twitter. For example, there was some questioning around, or, you know, were the patients forced to taper their opioids? I mean, obviously you would get results, they all volunteered. So obviously you're going to have a bias in a population. So that really informed my interviews. So when I was doing interviews, I was able to really emphasize those points, that actually it wasn't a forced taper, it was a shared decision making. And these types of programs, you will have an element of people volunteering because they are at that motivational stage already of being curious and perhaps wanting to, they may not have been 100% wanting to reduce their opioids, but they were at least ready to learn more about it. So, thinking about research and impact, and when you communicate and how you communicate results, any kind of feedback you get from any type of platform is really useful, and you can use that for when you're presenting. So gather those questions, gather that information, and that just strengthens really any type of communication that you do. So where are we now with the study, and where do we go from here? So currently we are the largest trial globally of this kind, and we are kind of leading in terms of a non-opioid, non-pharmacological type intervention to help people taper. So really for us now, we want to implement this. We want to look at a rollout. So in May 2023, we had the JAMA publication. And then we have been working with NHS England, and at the time, the National Patient Safety Improvement Programme, which had funding available for a year to help support some of these, the rollout of such programs, or at least get discussions going with leads across different regions. We also had some support from the Warwick Innovation District, and now the Warwick Innovation team are still very much involved with our iWatch program, and so they are helping us navigate through what this intervention could look like as we continue with the rollout and service evaluation. And then it really meant going out to stakeholders and doing meetings. So similar to this, I was doing webinars, explaining what the study was, and then giving clinicians an opportunity to ask questions about how they can get such a program into their service. And as you can see, in January 2024, there we've got a list of different services, NHS sites that have signed up to be our interested in iWatch, and then also interested in delivering a program as part of the service evaluation. So what we want to do is we want to support these services to train their clinicians, deliver iWatch, and then we will collect data in terms of, what has worked, what were the challenges, what were the facilitators, in order to then go on to the next stage of hopefully a wider rollout. So what we've learned is that you do need to have the time to invest for these webinars, for these conversations. And we also have different funding models to help that. So there's a Medical Research Council, the NIHR also has other funding opportunities, and obviously Warwick Innovation as well. So where we are at the moment is we have one clinic that has delivered in Southwest London for us, and we're waiting for some data. And we have another clinic in the north of England who will be starting in January. And then I'm getting emails now from other clinics who are very interested, but because we've already started the service evaluation, we have to draw a line of, okay, when we stop that data collection to say, and then produce reports to further support rollout of this intervention. So what we have found so far is engagement is good, the interest is good, the motivation of service leads is good, and that's very important because the service leads have to be the ones that really motivate, obviously, the staff as well to be able to take part in our training. The lay facilitators, that's quite interesting because what we want to do is we want to develop a hub of people that can deliver iWatch. And we've already started to understand what that can look like. So in the trial, it's very different because you have much more strict timelines, you have certain groups and communities that you have access to, whereas now in the real world, we are very much being guided by which services have what communities near them. So we're learning through that, which is, but it's working. We have a manualized program, and what we've had feedback is that this type of program is good to deliver because you can train people and they know step by step what they should be doing. Also, I guess resources and infrastructure is important. So in any type of multi-component intervention, we need to think about when we are taking it from a research setting into the real world setting, what infrastructure is available for the staff, what materials do they need, what venues do they need, what time do they need, all those components have to be discussed and really have to be in place, because with the research study, our funding model is very different to when it's a real world. Obviously for us, when you go into real world implementation with any study, ensuring safety of patients is key. So when I'm getting asked questions of, oh, can we do this with iWatch? Can we take this bit and do that bit? We haven't tested that. Our evidence-based program is iWatch as it is. So we want to ensure that, you know, the safety of patients is crucial for us. So I guess where we go from here is, so just recently in the New England Journal of Medicine, our colleagues in Australia presented a review of what evidence is available now in terms of opioid tapering, and really what are the principles of opioid tapering. And our study was included in this review. And they've come up with a list of principles, and really I guess our mission with iWatch very much map onto these principles. So making sure patients are informed, empowering them with shared decision making, having that personalized plan, thinking about the ethics, so making sure there's informed consent, being aware of patient fear, making sure it's gradual dose reduction, so it's not forced, clear communication, so whether that's we need more training and motivational interviewing of our clinicians, and really, you know, supporting the different types of interventions. And for iWatch's case, it's the pain management strategies. So when I talk now about implementation, I have principles that I can map on and use when I want to go on to talk about policy change and so on. So in summary of our main findings, that the iWatch intervention did work. The number needed to treat for complete opioid cessation was about 4 to 5. There was no increase in pain or pain-related disability, which was a great finding in itself. And replicate, now we do want to replicate it. We want to look at different clinical settings. And obviously we're looking at our international reach as well. So we do have a colleague in Canada who's very much involved in this, who's supporting kind of rollout or any sort of messages that from iWatch it there. And basically, yeah, we want to see where the next really few years goes after the study. So as I said, this is not a team of one. I'm a CI, Chief Investigator, with Sam Aldarbe on this, but everyone else was a co-investigator. So you can see, I mean, that's our co-investigators. Behind this, there was a whole other host of team members that really, you know, ran the day-to-day running of the study. So it was a huge study. And for me personally, this was my first big trial as a chief investigator. So, you know, it's been a massive learning curve for me. I've learned a lot about leadership. I've done a lot of leadership training alongside this program of work. I've done everything from presentation skill training to media training, to learning new bits around behavior change and methodology and chronic pain and opioid reduction. So it's the complexity of this trial has allowed for a lot of other development alongside that, which I'm very grateful for. And that's it really for me. So thank you for your attention. I'm just going to put the light on so you can see me.
Hubs, that's amazing. And I already see the colleagues have got, they're ready to go. We've got a few hands up already.
Fabulous. Okay. Do you want me to stop sharing? Shall I do
Yes,
that?
if that's okay. Yeah, so you can see the participants.
Yeah.
And I believe Ivan was the first one to raise your hand. I think I'm just going to go in the order that I see it in the list.
That's great.
Yeah, thanks. Regarding the presentation, actually, it was a question about a slide with a mobile application with like dose per week. So my question is about how did you calculate the percent of reduction? So it was 10%, if I'm not mistaken.
Yes, it was 10%. So that was our clinical team. So they had all the, I guess, the formula behind that of each of the different types of opioids, the different combinations, and with the programming team and the clinician input, all of the different types of combinations are in that app. So basically whatever is plugged into that, the 10% reduction is calculated, and then until 30% is reached, then 10% of that. But I should say with the app, although it was used mainly for the study, we did say to our clinicians it is more of a guide, and actually the GP had the final say of whether they stuck to that 10% reduction or not. So if, for example, the patient actually didn't benefit from, maybe it was too fast for the patient, or maybe it was too slow, then the GP could change that. But I have to say, we only probably had 3 or 4 times when the GP got in touch with us to alter the plan. Otherwise, that 10% reduction worked. We have had a lot of interest in the app. We did base it again on what guidance was available at the time, which was the Faculty of Pain Medicine. So those were the sort of morphine equivalent doses that were used. But anything we do now is being updated. So again, that is our clinicians that are doing that. Sorry, I got distracted because I can't see the chat coming up on my side.
I know
of my screen.
it's already buzzing, which is great. I know we have more questions from the audience, and then we'll go to the chat in a moment. I'm wondering if Artem, if you wanted to go next.
Yeah, thanks a lot for your very interesting presentation, and I'm sure that's a very important study, despite it's not my main field, and therefore I'd like to ask a question from data protection point of view, and just in case how do you ensure the confidentiality of such sensitive patient data during the study, and will you store this data after the study will be finished?
Yeah, that's a really good question, actually, and I do appreciate, by the way, that this may not be your topic area, so I appreciate your enthusiasm from all of you to listen to the study. So I guess in the CTU we follow standard operating procedures. So we have very strict guidance on confidentiality of data. Everything is anonymized in terms of our data sets. Everything's obviously monitored and stored here. In terms of anything that's published, there is no patient data at all, which is associated with anything that's published. We do also have a data monitoring committee, which would meet to check that everything is being adhered to. They would look at our data. Our statistical team would have to present reports as well. And I guess, in terms of everything that's transferred from the GP practices to us is done in a secured way and then stored on a secured shared drive here. So even with the interviews, the qualitative data, I have no access to any names. Everything is anonymized for that as well. So, and that was made very clear in our information sheets as well. So when patients join the study, quite often one of the questions is, well, am I going to be identified? A lot of stigma related to this topic as well. So we ensure them that absolutely not, no.
Wow, it is an interesting question.
Yeah, and very good answer. Thank you very much. That's really detailed.
I was wondering, as a PI, did you have to do the application for the ethics side of things? Now we're in the topic, so you had to do all the paperwork.
Yeah,
wow.
So I actually had a research fellow at the time that joined the study. So we worked on it together, and then so in terms of the team of a CTU, we have had a research fellow. I also had a project manager and a senior project manager. So those are really the day-to-day. They're so used to pulling stuff together. So it was literally a big team that got this through. And even with the ethics side of it, we had to do quite a few amendments as we were going on, because, you think, and that was one of my big learning points through the study, because I thought, once I've got it, we've done the ethics, it's all done. And then we have our monthly trial management meetings, and then something comes up and we think, we have to amend that, or we need to do that. We didn't think about that. And that really upset me first, because I thought, oh no, why didn't we think of this? But actually, I've learned that is a part of the pragmatic side of the study. You can't think of everything all the time. So small little tweaks are okay, as long as it all goes through ethics and you get the approvals.
Yeah, thank you so much. I see that Victoria was next on the list, but also Olha will be next, and I know she's already nodding, so I know there's going to be a good question there. Victoria, over to you.
Okay, thank you very much. Good evening, first of all. And I want to say that thank you so much for such essential information. Unfortunately, I'm also far from medical field, but I really appreciate your experience in behavioral science and health psychology. So my question is the following. You have devoted significant attention to communication in your career, like doctor-patient interactions, motivations, support. And in your view, what principles of communication and motivation can be applied in teaching, especially when working with IT students who often need, strong self-discipline and self-management skills? So maybe you can give some advice about this.
Sure. So I just missed that bit. So was it IT students, did you say?
Yes, IT students.
Okay.
Yes, IT students.
Okay. Yeah, okay. That's a really good question, because I guess when we talk about communication, it does apply to everything. It applies to everything we do, whether your communication results, whether you're trying to motivate your team, whether it's with students, healthcare professionals. I think the key thing is when we talk about any sort of behavioral change in terms of motivation, it's getting them to understand, first of all, what are their beliefs? What do they actually feel they are going to get out of whatever course or whatever they're doing? What are their goals? Like what is it actually they want to achieve and learn? Because really they have to be able to understand why they're doing what they're doing, in terms of then understanding what their motivation is to be able to do that. Now, when we were motivating our staff in terms of motivational interviewing, we gave them examples of, if you were to see a patient, for example, that was quite challenging and had quite resistance to what you were saying, quite often we as communicators can become quite resistant as well. And, before you know it, you've got barriers there. So actually, sometimes it's actually understanding where that resistance is coming from, and perhaps rolling with that a little bit and trying to unpick perhaps where good achievements have been made in the past, or perhaps understanding why they're feeling quite challenged at that time, and not always coming up with a solution. I think that sometimes when you continuously are trying to tell, that sometimes can be a little bit demotivating. So by getting them more engaged and helping them to think of the solutions, that is what I think helped them feel involved in that decision making. But I totally appreciate that, because motivating is hard, but understanding there's two levels of motivation, like we did there. There's that the reflective one, where people are more conscious about it. Actually, what are my beliefs? Why am I doing this? Is it something that I really want to do? Yes, it is. Okay, well, how am I going to get there? Whereas the automatic one is that subconscious, where the habitual behaviors come in. Oh, actually, I'm not really interested in that lecture. Oh, actually, I'd rather go and see my friends anyway, so I think I'll do that. So it's understanding what behaviors are being guided by what. And in terms of communication for you, it's whatever materials you have, it's perhaps designing the way that you deliver them based on that.
Okay.
I hope that was sort of helpful.
Yeah, so identifying aims is a key point. So it has sense. Thank you so much. Thank you so much again.
Thank you, Shara. I love the lateral thinking here as well, right? Like, how can we apply this to other areas? Olha, over to you. Thank you for
waiting. I've never been asked that before. That's great.
This is like a new career, right? Like communication expert.
I wanted to thank you for your presentation as well. It's also not my area of expertise, and I guess my question stems from Victoria's, because it's also about communication. I was wondering if your study or trial was affected by the pandemic. So if you had to deal with social distancing and moving your interventions into the online space, and whether you think it would affect the results or maybe help scale the outcomes. So
that's a really, really good question. So I guess so the first part of that question, yes, we were impacted by the COVID pandemic. But thank God that all of our interventions had been delivered. So if the interventions weren't delivered, I think we would have been quite we would have had to really redesign, and like you said, perhaps go into the online space. I think we were at the follow-up stage. So what we wanted to do is go back into GP practices to collect their data from sort of prescribing data, what's been happening over the sort of really the 12 months to inform our health economic modelling. Unfortunately, that's what we were unable to do. So we were only able to go into a handful of GP practices. And that meant that for the health economics team, they didn't have as much data as they would have liked in terms of informing that model. In terms of where we go from here, so it's quite interesting because naturally in practice, a lot of these face-to-face programs did go online. And there are a few services now that still deliver online programs. In our clinical trials unit here, we also delivered another clinical trial on people with long COVID. And it was led by Professor Gordon McGregor, who is a exercise physiologist. And again, the behavioral change input was very much based on the COM-B model again. But what we found is that it did actually improve quality of life. So people still attended this online program and felt connected in a group. So that to us is showing that we can train our clinicians to deliver a self-management type program, psychosocial support sessions online, and people are still feeling connected. So now we do have other trials which are being designed with online rehabilitation programs. And for iWatch, I think our next step will be to digitalize it. So we will be looking at online as well. So brilliant question, and absolutely.
Thank you so much, Olga. Before I go to the next person with the hand raised, Harvis, I just wanted to draw your attention to some stuff in the chat, because I think Tamara, who's asked like 3 questions, is probably from your field based on the questions she's asking.
Okay.
And Tamara, if you're able, please feel free to unmute and come on, come and join us. I'm assuming you probably just can't speak, hence the questions in chat. So, Harvis, can you see the first question? It's, can we name the health model of treating cardiovascular disease that include component of pharmaceutical management in general complex intervention in a context of cost-benefit analysis?
So I can't
it's a question from 350. If you just scroll up a little bit, and that's where I left a comment to say one of the words means stroke. Can you see?
Oh, yes. Can we name the health model of treating cardiovascular disease that includes component of pharmaceutical management in general complex intervention? Okay. Also, have we a comparator? So in terms of the health model of treating cardiovascular disease, do you mean in terms of the behavioral change aspect? I'm not quite sure I quite understand the question. I might have just totally missed that.
Good evening,
hi,
dear colleague. Yes, my question is about the real world data that we have. In Ukraine, we have the standard model of care that include patient and physician in also combination, yes, but a new model, we input in this model pharmacist, and we look at the adherence level and want to calculate the cost benefit of how adherence level impact of MACE, insult, heart attack, and Can we name this complex? Yes. Do you know any such type of trials maybe? And how do you think it's in general, do you ever see such type of cost effectiveness, maybe a cost benefit analysis? Because I know that there are a small of this type of analysis because it's so complex. Yes.
Yeah, no, absolutely. And actually, so we did have, and I'm sorry, I haven't presented those results because they will be the better ones to explain that complexity. But we have a team at the University of York who have led on the health economic modelling for this. So I understand what you're saying in terms of the cost benefits analysis, and they have looked. So what is fed into that model is obviously, like you said, the adherence. We did want to look at that 12 months prescribing and sort of, try and work out what the opioid pattern would be for someone who is tapering. For example, how much would they relapse perhaps and go back into the system? And they've had to do a lot of predictive modeling on that. I would say in terms of the answer then to that is I am really hopeful that our publication will be out in the next couple of months. I'm happy to pass on to Bo the details of the health economic modelling once it's done, which you are more welcome to get in touch if you have any questions about it then. And I could probably ask the team to answer it much better than I would be able to understand that complexity of the health economics modelling.
Super. I'll just pop. Yeah, go ahead, Tamara, go ahead.
Thank you very much. Also, I have such two questions maybe after, or I can ask you now.
Yeah, go for it, Tamara. Whilst you're online now, go for it, ask them, and then we'll go to Alina next.
Also, I'm interested in general. It's my interest in my cup of tea. How do you think? I want your opinion about the patient-oriented outcomes in the context of health, pain, cure. Of this is different type of patient. What is more important for this patient? Overall survival or PFC? Yes, because in cost effectiveness analysis, we also say that PFC is more important because if we're talking about the OS, there are a lot of different subsequent therapies that also give us a lot of uncertainties and so on. What is your opinion? What is more important for patient in the...
Yeah, I guess, for a lot of patients, I guess in terms of what we're trying to achieve with them, is that quality of life. It's being able to live with their condition. So we are not looking at curing and what we want to, and it does depend a lot on what the research question is. Like, for example, for this particular study, the research question here was, can we help people reduce their opioids? So ultimately the opioid reduction is quite a obvious reduction. But then we also know that pain has a massive impact on daily living, and in particular pain interference. So in this sense, the research question, or what we wanted to answer, was around pain interference. Does it affect their day-to-day living? We could have gone for pain intensity, but really we know from previous research and our programs that we don't always have an impact on their pain intensity, but what we do have an impact on is how they manage their pain. So I would say, it really does depend on the research question, but ultimately what we're hoping to do with patients is to increase their quality of life, so they're able to live with their pain. I think also with this particular program, they were self-reported questionnaires that we used. We were asked, because we did publish it in JAMA as well, and one of our limitations we've included in the discussion was that we didn't collect urine samples or have those data to kind of show, but general practice in the UK is we wouldn't do that anyway. So we generally would ask the patients, what opioids are they taking? Whereas we know in other healthcare systems, they may be taking, for example, urine samples. So yeah, I think it's complex, but it really much does depend on the research question.
Thank you. And the last question from me, did you publish your trial on the trial.gov UA?
Yes.
Yeah. And how do you think? I also look up the site, and I see that a lot of trials don't have the published results. I have the question: why is so? If they any have the bad results, it's also the results, yes? And
absolutely,
we should have this.
Absolutely, I agree with that. And there is obviously there's a whole other debate and question on publication bias as well. Obviously, yes, but yeah, no, we've published in the main journal, which is JAMA, and our NIHR, which is our funding body. I'm just completing the final monograph, which is the 50,000 word report. that would hopefully be published, and that will have all the health economics data in it within hopefully the next couple of months, and then that will be available, and that has much more detail than obviously the JAMA publication does. But you're absolutely right, you know, a result is a result, and I was prepared when I started this study to kind of really go out there and communicate whatever the result was. So, for example, if it wasn't successful or significant, then that's a finding in itself that this type of program doesn't work. But I agree, you know, and even though this is successful, it's still not a one size fits all. So this type of programming is not going to be useful for everybody, but we do know it works for those 29% that we're able to reduce. So yeah, I agree with your comment. I think that's important, that we shouldn't be just focusing obviously on the successful ones, because we can learn from those that aren't successful as well.
Thank you so much. We still have 5 questions live and then 1 more in chat. Alina, I'll go to you because I know you had your hand up first and then it disappeared and it popped up again. So over to you, please.
Yes, thank you very much, because I have very unstable internet connection. I don't know if you can hear me well now. Yes. Thank you very much for very interesting presentation. It was super interesting for me because it's my medical field. I'm a doctor. And I work as a neonatologist and pediatric neurologist in the neonatal intensive care unit on a daily basis. So I have a big deal with infants who have experience with pain, also with acute pain or later with chronic pain. So it was very interesting for me. But now I have, and also I want to add that our project also includes learning of behavioral patterns and change of it in response of this pain. But now I have a question related maybe for psychological aspect, which educational intervention or behavioral change intervention do you consider most effective for parents in improving these neurodevelopmental outcomes for infants in risk? Because it's also a circle, family circle, kid, family, and it's also a big problem for us. I just want to understand, maybe you can share your experience. Thank you very much.
Yeah, no, I think that's a really good question. I mean, I guess I should say that, you know, a lot of my trial and my work, I work with adults. So I guess what I don't want to do is generalize to sort of pediatric or sort of infant care as well. But, you know, I mean, from my experience, the behavioral interventions and those that have a CBT element, and even now there is a lot more evidence coming out on therapeutic approaches involving things like mindfulness as well within that, have shown to be effective. But you know, and I think there's probably a whole host of research. I mean, I'd have to go away and have a look into what the current effectiveness is for that, for particular infants and so on. Because also, I guess you've got a different dynamic here as well, because you've not only got the infant or child, but you have the parents or the carers. So actually the model is different. And from a psychological perspective, that is very key to understand those dynamics, and making sure that obviously whoever is involved in that care has the support they need. And you're dealing with different layers, I guess, of the psychological aspects. Is that hello?
Yeah, we can still hear you. It's all good. Yeah. we're just like literally on the edge of our seat, like listening to you. It's really interesting.
Yeah, that's very good. Very interesting.
Thank you, Habs. Let's go to Michaela. Michaela, over to you.
Good evening. it is very interesting that you used app and dived in your research, and I tried just now to find it on official Android repository in Google Play Store, and I didn't find it. So the question is, in what way, how did you distribute the app to the patients, and why that particular way? Also, when the app was developed, did you use or develop some guidelines about privacy respecting coding? Something like avoiding common built-in tracking libraries, which is by the way are used in almost all apps in Play Store, and it is really hard to explain to developers why is it bad to use them. Thanks.
Yeah. Okay, that's a really good question. So I guess with the app, the reason why it's not available yet, or you can't find anything about it, is because we're still testing it, obviously, in the service evaluation. So our manuals and everything are still being we're still delivering it in that aspect. So in terms of how the app was developed, so the coding was done, like I said, with our programming team, and it was actually on a tablet, and then it wasn't the patient that got the app, so it was the clinical nurse that had the app. So during the one-to-one appointment, the patient would come in with their whatever they were taking, their list of medications, and then the nurse would literally plug into the app what they were taking. So all that pre-coding was done, and you're absolutely right. We've got I mean, I have to put my hands up. I don't understand all the coding that goes on behind with all the spreadsheets. It looks very impressive. But yes, so our programming team does have their guidance on how that was developed. And even now with our service evaluation, we've actually collaborating with an external company who has taken the app for us, because obviously during the trial, everything was in-house with our programming team. And now we're in the post-trial. We got a bit of funding that we were able then to outsource that work. So now this company is helping us do all the coding, although we are providing them with all of that. So that included our clinician having to sit through all of any updates from the Faculty of Pain Medicine in terms of morphine equivalent doses to ensure everything is up to date. The only guidance we gave was to our clinical nurses of how to use the app. So they had a one-day training of here's the app, this is how you use it, plug it in, see what it generates. And then they were able to ask questions, and we were always available to troubleshoot. I say I'm not the technical expert, so I would then normally just pass that on to our programming team.
Brilliant, thank you.
Great. That was a really nice way to circumvent any privacy-related issues with applications. Thanks.
Yeah. I should also say, I should also say with the app, again, in terms of anonymized data, everything was secure. And what the app did actually do was all the data from the app was sent back to us here. So it wasn't stored in the app. Nothing is stored in the tablet. All the service is based here in the Warwick CTU. So everything is handled safely and confidentially.
Thank you. I'll take 3 more questions because we're rapidly running out of time. We have about 12 minutes before we need to close the session. No, this is fantastic. This is exactly what we were saying to you. Like, the cohort is so engaged, which is great. So Ina, over to you. You're next.
Thank you very much. Thank you for your presentation. And I have a question. Did you have request of data withdrawal? I understand that data is anonymized and it's not personal, but in any way, did you have this, and how did you deal with that?
Yeah, that's a really good question. Now, ethically, unfortunately, when someone does decide to withdraw from a study, we can't go back and ask them, sort of interview them as in why did you decide to withdraw? But sometimes they would give us information. I haven't got the list with me. I think that list may be published in our final monograph because we have more data there. I can definitely find out if you wanted to know more as well. But the kind of things were around, it just wasn't the right time, or perhaps, an appointment came up and they were unable to attend. There was nothing in the reasons why they withdraw that alarmed us to think we need to change the design of the study. They're sort of the kind of typical things we would see in clinical practice. I don't think we had anyone that was, fearful, let's say, of what the program was going to do or withdrawal. I think it was more of practical reasons, sort of just changing their mind of not wanting to be in the study. Yeah.
Thank you.
Thank you.
Nadia, over to you, please.
Thank you so much. Well, I'll try to. Yeah. So I also work in the medical research, and we have recently had the big research that engaged patients. And what I want to ask you is basically, how do you start the recruitment of patients in those very initial steps? Because what we have tried and what we've noticed is when we went through the doctors and to the healthcare facilities, sometimes healthcare workers try to propose us the patients that they wanted to, they had different reasons for that. But we wanted to make the cohort as well as different as representative as possible. So how do you get to those people in the very beginning?
Yeah, that's a really good question. And as you see, like I presented I think 3% of our population identify themselves as other than white. So that we definitely have, it's not that generalizable, our results in terms of that side. But I guess in terms of our recruitment, what we did is we opened it up, 191 GP practices. We did site initiation visits for each of the practices. I did try and attend as many as I could of those. And I think that also made a little bit of a difference, especially at the beginning, because you going as, with your team, as I guess the CI of a study, it shows a little bit of that commitment. You can, really explain the study as well. And the team were great too. And to be honest, because of the nature of the study and the topic, I honestly didn't feel like any of the GPs were resistant to joining. Actually, they wanted to join. And to be honest, I had to turn some GP practices away because I was getting emails throughout the whole lifetime of the study. And, it got to a point where we had to stop. So that helped as well. And I think when you've got a proactive GP practice, that also helps with recruitment because then, I guess that infrastructure is there. In terms of how we recruited our patients, because we screened them, the list, and then they were sent basically invitation letters, it was really up to the participant whether they joined or not. So to some extent then, those that did were the ones that were that little bit more motivated to volunteer, which was again, what you would expect in these sort of self-selecting trials. In terms of, inclusion and diversity, I think now when we do our other studies, we would look at, really how, and even we're doing that now in some of our other trials, what do we need to do to get to those communities? Communication, attending community meetings, whatever that may be, leads within communities and engaging more on that side, I think is probably, and we have within the trials unit as well, we have a developing working group really to specifically target inclusion and diversity in our trials. So I think this is definitely something that we are keen on expanding on in our trials. Good question. Thank you.
Thank you.
Thank you. And last but not least, Larissa.
Good evening. First of all, thank you for your presentation, for your work. I am interested in behavioral interventions for a few years, but in the context of public administration, so my question will be general, maybe. Okay. How do you think, what are key risks in using behavioral interventions to manage human behavior?
Yeah, it's a good question. It's a very generic question. I think I guess if I look at this study, we did a risk assessment for it, and we regularly looked at that risk assessment throughout the life of the study, and actually the risks were quite low because we were giving a non-pharmacological intervention. In terms of the behavioral side, nothing is ever forced and patients have to feel empowered to do it. So I think in terms of risks to the patient, as long as your framework and your models are mapped onto the behaviors that you are trying to change, and you have that outlook on patient safety, I think the risks should be manageable and hopefully not high. But obviously I can't speak for, it depends on your research study, it depends on your population. Here, for our particular population, these were people that were reducing their opioids. So our biggest concern was the withdrawal of as they taper. So what we then put into place is having clinicians that were available if they needed to be contacted if a patient was seriously concerned. We also had, like I said, our data monitoring committee, which would look at all our serious adverse effects, which have to be reported under our standard operating procedures. So it really does depend on the study. But in terms of the behavioral aspect, I think because we had mapped on all our behavior change techniques, our behavior change framework, we were able to identify where the potential risk was. And for us, it was that, that kind of withdrawal part, especially. And that's the feedback we got from our patients as well. That was their biggest fear. But then we're able to manage that through looking at behavioral model and thinking, okay, what information around managing anxieties and fears can we then include to help mitigate those concerns?
Thank you.
Answers your question.
Thank you for your answer.
Thank you.
Okay.
Ludmila, I know we have a few more in chat, but I just wanted to check with you if you maybe needed to use those final few moments to close the session and say anything else.
Yeah, no, absolutely. I just want to thank you all again for the opportunity to, really speak about the trial. And I hope, and like I said, I do appreciate it's not everyone's topic, but I hope that I gave a bit of an insight also into just delivering a large complex trial from start to finish and then implementation and where we go from there. And if any of you are interested in anything with our sort of Warwick CTU side, I've said to Bo, please do get in touch, and we're sort of happy to answer any questions.
Thank you so much for your key items and insights, and it was great. Thank you. And I think that we can finish. Yes, Bojana.
Just to say huge thanks again to echo Ludmila's point, and I know Ulana is passing on her thanks but couldn't stay all the way to the session. I mean, it's really engaging, and I know there's more questions again about the collaborations, about your next plans. So I do really hope that we'll have Harbinder at some of the social events that we'll be having when people are on campus, and hopefully we can also share some of your profiles as well, so people can continue following the amazing research that you're doing. So please just join me in kind of virtual applause again, and despite the lights and everything else that was going on both sides of the call, right? We've gone through the session. So really, really huge thanks for being such a role model, for sharing your work today, and for taking the time to spend during a busy time of the year with this cohort. So huge thanks.
Brilliant. Thank you so much, and I wish you all the best and good luck with everything that you're doing.
Thank you so much.
Thank you. Bye.
Bye. Bye.
Thank you.
Bye. Goodbye.
Thank you. Bye.
Thank you so much.
Thanks, everyone. We'll see you next week.
Thank you so much. Have a nice evening.
Thank you, Lilia. So we can get through to all of the questions. All right, I'll say bye, Harbs. Thanks so
Okay,
much. That was
I'll
amazing.
log off. I just thought,
Sending
but
all
just
my love. You've
yeah,
been brilliant.
no problem.
Thank you.
I'll drop you an email and then we can
Yeah.
just go. Right. See you later. Bye.
Lots
Bye-bye.
of love. Thanks so much
Bye.
again. Bye-bye.